Good afternoon, everyone, and welcome. I'm glad you're here. And as we come together to talk about something that touches us all, skin cancer. So, this isn't just a medical topic, it's a community one. It's about making sure everyone, no matter their background or skin tone, has the knowledge and tools to protect themselves. Today's forum is a chance to learn, share, and ask questions in a space built on trust and care. So, let's get skin deep, listen to each other, and keep moving forward together
Oh yeah, I got it.
towards a world where everyone has what they need to stay healthy. And so, with that being said, again, to the top right, if you haven't already, please go ahead and scan that for our pre-form survey. As you can see right here, we have our agenda for the day. So we're already rolling through our welcome and our pre-form survey. And as you can see, we're moving and we're hitting hot like a train. And we're going to keep it moving to our speaker introduction, which I think you're going to be excited about that. From there, you'll have our presentation on spotting skin cancer, followed by a Q&A, and then you'll kind of have our Massey Cancer resources, watch parties, and other things. So, moving forward onto our speaker introduction. Today, I have the distinct pleasure of introducing our speaker of the day. So, our speaker is Dr. Kimberly Salke. She is a dermatologist at VCU Health and an associate professor and the residency program director in the Department of Dermatology here at VCU and VCU Health. Today, she'll be talking about how do we normal age related to skin, changes different from the sun related to skin changes, the different types of skin cancer, and how can you reduce your risk of skin cancer. She is very impactful. I'm excited for this speaker. I hope y'all are excited as well. And without further ado, I will not take up her time. I'm introducing Dr. Kimberly Salke.
All right. Wow, that was quite an introduction. Thank you very much. I'm excited to be here and share about spotting skin cancer. Did I hear you can see my slides okay?
Yes, we can see your
Okay,
slides.
perfect. Okay, good. All right, so this is a topic important to everybody, just like you heard. So I'm going to dive right into it, spotting skin cancer. Just the facts. Warning, there will be a quiz. So here it is. We're going to start right from the top. Which of the following is true? More people are diagnosed with skin cancer each year in the US than all other cancers combined. More than 9,500 Americans diagnosed with skin cancer every day. 1 in 5 Americans will develop some form of skin cancer by age 70, or more than 2 people die of skin cancer in the US every hour. Hmm.
All four.
All right, all right. We've got some votes there. So if you said they're all true, you're right. These are all true. So I wanted to start with this just to point out how big of an impact skin cancer has on all of us. So, as you heard, I'm going to talk about aging skin. I'll talk about different types of skin cancer, some strategies for prevention, and then we'll end up with some myth busting here. So, I want to make sure that we've got just the facts. So when it comes to skin aging, it actually happens in two different forms. So there's chronological aging, and that's the stuff that happens over time. That's genetics. That's stuff you can't control. Biochemical changes that we see in the skin. That's thinning of the fat underneath the skin. And so what we can see is less elasticity. We can see bruising. We can see sagging of the skin, and that we don't have a lot of control over. Even the dryness part, so the number of oil glands you have and how active they are is genetic. And so when they start to decrease in function, we see some dryness of the skin. Now, that is in contrast to photoaging. So that term photo refers to the sun. So UV light and things that happen as a result of sun exposure. So the things we see related to that are things like fine lines and discoloration. So those brown spots, liver spots. My patients talk about their age spots all the time, and I love to point out that the skin on your belly or in your bottom is the same age, but it does not contain the same spots. So those are related to sun exposure. Other changes we can see related to sun include dilated blood vessels, and that can lead to some redness or splotchiness of the skin too. So let's look at some examples. Here we're looking at photoaging kind of changes. So looking at these deep wrinkles of the skin. Here we can see some redness on this patient's neck. And then on the back of the patient's hand at the bottom, we see those liver spots or age spots. I hope you can see me using my air quotes because these are sun spots that we're talking about here. This is one of my favorite pictures to share in settings like this because this is an excellent example of photo aging versus that biological aging or chronologic aging. So this looks like pictures taken on different days, right? Or maybe two different people. But what we're looking at is two different sides of the same woman's face. And she worked in an office for 30 years. And guess which side of her face the window was on? And so it's this one on the left, and you can see the wrinkles, the discoloration, the changes in the skin on this left side of her face compared to the right. And that's because that side was next to the window for all those years. We see a similar thing like that in regular folks who don't work in an office setting like this. When we think about driving in that driver's side window, we get a lot of sun right through that window. And in fact, we do see more skin cancer on that left side of the face compared to on the right. And I think everybody can recognize the photo aging that's going on in this picture. So let's move on and talk about different types of skin cancer. And we're going to cover a little bit about each of these in this order. First up is basal cell carcinoma. So this is the most common form of skin cancer. And in fact, it's the most common cancer that we see in the US. Here you can see 3.6 million cases of BCC every year. I like this cartoon. It says, skin cancer? You mean that scab I picked? And so a common presentation for basal cell is a pimple or a scab that just doesn't heal despite not getting picked on. So something that spontaneously breaks open, keeps a scab, that should get your attention for sure. This is how it looks under the microscope. So we're looking at these purple cells that ought to be limited just to the top part of the skin, but here they're breaking down deeper into the skin, and that is what basal cell looks like under the microscope. In person, it looks like kind of a pearly papule, how you'll see it described in the book. Almost kind of looks like a blister or like it might have some fluid in there. And then we can see prominent blood vessels across the surface and sometimes even a crust or a scab on the top. So here are some examples. So it's no surprise or coincidence that we're looking at head and neck kind of areas because this is something we see related to sun exposure, and those are places that get the most sun. So right there on the nose, couple on the nose here. Again, the patient would tell you this is something that's been there for months or years and just hasn't healed. And here we can see one on this patient's ear as well. This is a larger one that has probably been unaddressed for a long time. So basal cell is the most common. It also happens to be the least aggressive. So it's one that takes about 6 months or sometimes longer to double in size. So something that starts out a millimeter or two, 6 months or even a year later, then it's 2 millimeters and then a little bigger. So it takes a long time for it to grow large. This is a person who probably neglected this basal cell for decades, but you can see that it extends all the way out over here by the eye and then all the way back in front of this patient's ear and down onto the cheek. So again, this is unusual for it to be quite this advanced, usually grows very slowly. I included this picture to show you that we see skin cancer in people of all different skin tones. So this is an African American person who's got a basal cell here, kind of a similar location to what we were looking at on the last patient. But this one is pigmented. And so in this darkly pigmented person, they've also got some pigment in their basal cell skin cancer. And that's that about basal cell. Next, we're going to talk about actinic keratosis. This is one that we think of as a precancer. So we know that somewhere between 1 and 3% of these go on to develop into squamous cell carcinoma, which we'll talk about in just a bit. But this is an early stage, and so if we can get rid of these at an early stage, we can help reduce the number of cases of squamous cell carcinoma. I love this picture of all these folks on the beach because who knows how many actinic keratoses there are on all of these people. And actinic keratosis looks rough and scaly and feels rough too. So if you could rub your hand across the back of this person's hand, it would feel rough like sandpaper, and you would see some underlying redness to it. Whenever I do a skin exam, I tell patients, listen, sometimes we can feel things better than see them. And so I run my hands across certain areas, particularly the back of the hands and on the face too, because we certainly see these in areas where the most sun exposure happens. Here, this is the top of a man's bald scalp here, and all of these red places, and I'll say red and scaly places that are mixed around in here are all actinic keratoses. As I mentioned, they all have the potential to develop on into skin cancer, usually squamous cell. And I had a professor when I was a medical student who said it's sort of like having a bunch of lottery tickets. And so the more tickets you have, the more likely you are to win something, or in this case, develop a skin cancer, which would not be a winning situation. But we're here to learn all about it. Here's another patient across the forehead. You can see kind of some scaliness around here, and then this pinkness. And again, if you ran your hand across here, it would just feel rough like sandpaper. And then again on the back of this patient's hand. So not a coincidence that I'm showing scalps and faces and the backs of hands, because those are places that get a lot of sun exposure. So this is a patient who's treated for actinic keratosis. So in panel A, all the way on the left, she's just got some diffuse AKs or actinic keratoses on her face. In the middle picture, she's used a medication called Effudex or fluorouracil. Sometimes we refer to this as chemo cream. So this is a cream that selectively targets sun-damaged skin cells and destroys them, and that's why she's looking all red and miserable. But in the end, she's looking happy because this is a great way to clear a lot of actinic keratoses all at once instead of targeting individual lesions, which is what we sometimes do with the liquid nitrogen or the freezing canister in the clinic. So remember we said we want to treat squamous cell carcinoma, or sorry, we want to treat actinic keratoses because they can develop into squamous cell, but we know that this is not the most common kind of skin cancer because basal cell is, right? So remember we talked about basal cell just a few minutes ago. So squamous cell, the second most common kind of skin cancer. And remember I said basal cell is the least aggressive. So squamous cell is a little bit more aggressive, has a little bit more potential to metastasize or go to other parts of the body. We see about 1.8 million cases of squamous cell skin cancer in the US each year. This is how squamous cell looks under the microscope. And so again, we're looking at purple sort of cells that belong very superficially that are making their way deeper down into the skin. On the outside, it looks like a red or sometimes a purplish lump or bump, and it often has scale on top of it. So here under the microscope even, we can see these sort of loose skin cells that are stacked up here. What that looks like in real life is scaliness on top. So here's a good example. So we're looking at kind of some redness underneath, the bump there, and then we're looking at this big old hunk of scale that's just built right up on top there. We might even refer to this as a cutaneous horn. And so squamous cell can sometimes get that big stack of scaliness on top. I'll show you some more examples. So this patient's giving us kind of a twofer because we can see in the background here some pink scaly places. And do you remember the diagnosis for those? Those were our actinic keratoses. I know is right on the tip of everybody's tongue. And then we're also seeing these ones with this big scale on top here. So probably at least 3 squamous cell skin cancers on the back of this patient's hand too. And then here a larger one, a squamous cell on this patient's foot. This is unusual, probably was not treated for a time because it does take a while for them to get quite this large. This kind of skin cancer is one that we see particularly in patients who've undergone organ transplants. So you might know when you get a new organ or organ transplant, you have to use medications that suppress your immune response so your body doesn't reject the new organ. And those medications put patients at risk for skin cancer, particularly squamous cell. So people who've had organ transplants are about 100 times more likely than the general public to develop a squamous cell skin cancer. Here's another one on the back of this patient's hand. So remember we said kind of a reddish lump or bump. This one's almost sort of purplish, and then it's got that crust right in the middle there too. This is a squamous cell that's limited to this sort of ulcerated area on this patient's neck, but you can definitely see something else is going on here in the background. And so what we're seeing are radiation changes. So this is a person who had radiation therapy for some other kind of maybe a head and neck cancer, and has developed squamous cell in the area where that radiation was done. And so that's a risk, and patients need to watch their radiation sites for any kind of new growths that might develop in that area. I included this picture to remind you again that people of all different skin tones can develop skin cancer. So this is a patient who has discoid lupus. So this kind of lupus limited to the skin. And it makes for these light colored patches or white patches that you can see under the patient's eyes and on the lip. But that lower lip has some serious crust there, and that's a squamous cell carcinoma on this patient's lip. The patient's is more susceptible to developing a squamous cell because of the dyspigmentation or because of the loss of pigmentation in the skin. And so, and then it may have gone undetected if it was looked at as maybe part of his underlying skin disorder and maybe didn't get looked at quite so closely, or maybe he thought that it didn't deserve attention because it was just part of his skin disease. But a change like this with the crusting and oozing definitely deserves attention. So here you can see more than 15,000 people die of squamous cell carcinoma of the skin each year, and that's more than twice as many as from melanoma. So that might be surprising because we always think about melanoma as being the most deadly kind of skin cancer, and I'll talk about that in just a minute. But this really stems from the fact that squamous cell is so much more common. So we see many, many more cases of squamous cell than melanoma. And so more people die from it than melanoma. Here's another example. And this one you can see is pretty advanced, probably involving the majority of this patient's ear with some ulceration and crust there. I hope we are after everybody's lunchtime. Jarell mentioned over the lunch hour, but this is not something you want to be eating your lunch while I share. Sorry, I should have warned you at the beginning. Speaking of which, don't say I didn't warn you now. So this is a squamous cell that's developed in an ulcer on this patient's leg. And so a longstanding ulcer also sets a patient up for ongoing inflammation that can allow skin cancer to develop there too. So a squamous cell in a leg ulcer. So we're going to move on from there from squamous cell. Now we're going to talk about melanoma. So this is the one that we hear about the most, that people worry about the most, but I hope you've been able to see already, this is not the most common kind of skin cancer, and that's good. Because it can be very aggressive and can be very dangerous for patients. This is fact about a study done in the United Kingdom showing that the vast majority, 80% of, or 86% of melanoma is related to sun exposure. So that's something we can control, and we can manage how much sun exposure we get. And that also tells us that 14% related to, or not related to sun exposure. So sometimes patients say, well, the sun's never shined on that part of my body, so there's no need to check it for skin cancer, but that's just not true because it can show up anywhere. For men, the likelihood of developing, or sorry, men age 49 and under, the melanoma is the most common cancer that we see there. So similar for women, except that breast cancer and thyroid cancer are also there at the top of the list. I'm sorry, should I stop for a question or are we okay?
No, you're
We'll keep
fine. Keep
moving.
going.
Okay.
Yeah, they're excited. Don't you worry, they're coming.
Okay, all right, good. Melanoma can have a lot of variability in terms of the clinical appearance, but we think about the A, B, C, Ds of melanoma, and I'll talk about that in just a second, as the best, most accurate way to identify it. There are a few different variations or types of melanoma, and those vary based on the anatomic site where we see them most often and also the demographics, so sort of the age of the individual that we're seeing it in. So we'll touch on each of those things briefly. When it comes to looking for melanoma, we think about the rules, the A, B, C, D, and sometimes we add E also, but A stands for asymmetry. And so that means you should be able to draw a line right down the middle of a lesion. It should look the same on one side as it does on the other side. And I want to point out the things in this left-hand column are the normal ones, and the ones in the right-hand column are the ones that are breaking the rules. Asymmetry meaning should be a mirror image one side to the other. B stands for border. So we like to see a sharp border, not one that's scalloped and goes all around and not one that fades out into the periphery. We want to see sharp borders. C stands for color. So we like to see uniform color, not light areas and dark areas. And then D stands for diameter. So a normal mole is usually 6 millimeters or less. That's about the size of a pencil eraser. When we see ones that are larger than that, that gets our attention, but it's not always bad news. In particular, birthmarks tend to be a little larger than that. And sometimes we add an E, which stands for evolution. So something that is changing over time also makes it suspicious. Here's another example of those things, A, B, C, D. So again, this first one definitely not symmetric. The border and the color on those middle two are definitely not looking normal, and then a larger one on the far right. So superficial spreading melanoma, this is the most common type that we see in Caucasian individuals, counts for about 70% of melanomas that we see. We can see it in a kind of young demographic, so median age of 37. And this shows up as a change in a pre-existing mole. So something that used to be 6 millimeters and sharp and even, and now it's gotten larger and has developed light areas and dark areas on the skin. Here are a couple of examples of superficial spreading melanoma. I know you're running those A, B, C, Ds in the back of your mind. You're checking against the criteria, and you can see from across the room and maybe even from across the street that these spots definitely are not following those rules. Here again, that should catch your eye. What's going on with this one dark area right there in the corner? The person would probably tell you that that part is new, or maybe the brown part is new, but this is a change over time. Lentigo maligna melanoma is a kind that we see most often in older folks compared to the superficial spreading. So this one we see in median age of around 65, and this is the freckle on the face or chronically sun-exposed area that gradually changes over time. So this is a slower evolving kind of melanoma, and they can get to be really large, 3 to 20 centimeters in size. So I think we can see from looking at this patient's cheek that this is not a regular old sunspot. It's uneven, it's got different colors in there. And here, same thing. So this should be pretty striking. It's definitely breaking those A, B, C, D rules. And this individual would tell you that this has been changing over time. It may be a matter of looking at the pictures from the family reunion a few years back and really being able to see that this is different over time. Acral lentiginous melanoma is one that we see when melanoma occurs in Black folks. This is the kind that we see. So 50 to 70% of melanomas in African Americans and in Asians are this acral lentiginous. So this one occurs on palms and soles and also on nail beds. So those are not really places we think about when it comes to sun exposure, but they are important places to look at when you're examining your own skin. So everybody look at your palms right now and see if you see any moles on there. Do you see any moles? If you do, that's okay. Moles can be in that area, can be totally normal, but we want to watch those for changes too. Here, this is a pretty advanced acrolentiginous melanoma. You can see the nail plate is absent from there. We can see some pigmentation around the borders there, maybe giving us an idea of what it was like before, but pretty advanced acrolentiginous melanoma. And then nodular melanoma. So this is one we see in folks usually around age 50 or so. This is the one that comes up de novo is the term we use to describe it in medical terms, but basically means out of nowhere. And so this is the new mole that shows up once you get out of your 30s. So you stop getting new moles kind of in your late 20s, early 30s. New stuff definitely comes up after that. Lots of benign things, harmless stuff. But the new mole that breaks those ABCD rules should definitely raise your concern for potential melanoma. And then amelanotic melanoma, this is one that keeps all of us awake at night because it doesn't have those typical pigmentation features that we use to try to discern from normal moles. And so this can be just a skin-colored bump that's growing over time. Melanoma relies, the seriousness of it depends on how deep it goes into the skin. And so every melanoma doesn't have the same prognosis. It depends on the stage when it's diagnosed. So to give you an idea, all the way over on the left, we're looking at stage 0, which is limited to the very top layers of the skin. And then all the way on the right, we're looking at stage 4, which is an advanced case that goes all the way down into the blood vessels, and that gives it potential to travel to other parts of the body. Here, looking at the same information depicted in a different way, stage 0 on the left, very superficial, and then stage 4 on the right. Now, stay with me here. I know this is a graph that might seem a little bit boring, but the thing I want you to notice here is that this is a survival curve depending on the thickness of the melanoma. So the red line across the top is all superficial melanomas, and you can see that the 10-year survival rate all the way over on the right is still pretty close to 100%. 97, 95% after 10 years, whereas this green line shows melanoma that's traveled to distant sites, and the 10-year survival for that is much, much lower. This is looking at information from the CDC, looking at the frequency with which melanoma is diagnosed. And here you can see over the course of this time frame up to 2017, a gradual uptick or gradual increase in the number of cases of melanoma. So that's important for us to know about, and how that translates into us within the state of Virginia, and even here in Richmond where we are. Here you can see kind of middle-ish, maybe 16.3 to 22.8 or so per 100,000 cases of melanoma every year in our area. Before we finish talking about melanoma, I want to point out what is not melanoma. And so these are seborrheic keratoses. All of these pictures demonstrate common, benign, totally harmless growths that we see very frequently in many people, particularly adults. So you got to be 30 and up or so before these start to show up. And they bring patients into the office a lot because people see them and they worry, is the color uneven and the borders and all that? But these are totally harmless, completely benign, not melanoma. All right, so if we have a couple of more minutes, I want to go over a quiz. All right,
Yes, go
I'm
right
seeing the
ahead.
green light. All right, everybody get your mental notebooks ready because quiz questions are coming. Here we go. True or false, you can't get a sunburn on a cloudy day. What are we thinking? All right. Hopefully everybody's saying false because that is 100% false. And in fact, up to 80% of UV rays penetrate the clouds, depending on what kind of clouds are out there and how thick they are. This guy says, you'll be fine. They said, it's not that sunny out, they said. So some of the worst sunburns I've seen are from people who spend all day at Busch Gardens on a cloudy day and they get a terrible sunburn. So don't be that person. Got to use your sunscreen every single day on a rainy day like it is around here today, on your on your birthday, on Christmas, like every day, you need to have your sunscreen on your exposed skin. All right, here's our next question. True or false, I tan easily, so I can't get skin cancer. Now, anybody who's been paying attention for the last few minutes since I've been talking ought to get this one correct. That is false. So no matter how easily you tan or what your skin tone is, you can definitely still get skin cancer. And here's a case in point here. So Bob Marley, which y'all are familiar with, died from melanoma, and it was on his foot. So it was an acrolentiginous melanoma. And so again, people of all skin tones, as I showed you some examples in my talk already, all skin tones can get all skin cancers. I wanted to include this from the American Cancer Society just to point out a couple of things. So here on the top left points out that Caucasians are 20 times more likely to be diagnosed with skin cancer than African Americans. But that doesn't mean that African Americans don't get skin cancer, because we can. And then I wanted to point out this part at the bottom here too. So even though African Americans get less skin cancer, they are diagnosed at later stages. And there are a number of reasons for that, partly because Black people themselves, we may not think that we're at risk for skin cancer and therefore may not go to the doctor. But the other thing too is that sometimes our doctors don't have the level of suspicion that they should to be thinking, could this be a skin cancer because it is a Black patient? So we all need to be aware and to be looking for those things. All right, here's our next question. True or false? Better to get a base tan at the tanning salon before getting a lot of outdoor sun. All right. That is absolutely, definitely not true. Tanning beds are carcinogenic, just like cigarette smoking, or maybe worse. And I'll show you, I'll try to convince you in just a second here. This is tanning booths when the sun isn't giving you cancer fast enough. So that's about the way we see it in dermatology for sure. A couple of fast facts about indoor tanning. We know, just like I said, UV light is a proven human carcinogen. It causes cancer. Indoor tanning devices can have 10 to 15 times the UV rays that the sun does. And so even stronger, more potent at triggering skin cancer. And then here you can see at the bottom, more people get skin cancer because of indoor tanning than develop lung cancer from smoking. So let that sit with you for a second. If you're thinking about going to the tanning
Wow.
bed, you might as well take up smoking, because your risk of getting lung cancer from that is less than the risk of getting skin cancer from tanning beds. So just don't do it. Tell a friend, don't do it. All right, true or false, all sunscreen is created equal. One corn says to the other, I told you to wear sunscreen. All right, so this is not true. All sunscreen is not the same. There are certain things that you should be looking for when you go to choose your sunscreen. So broad spectrum is a thing that really is required nowadays. There was a time when there were just UVA or just UVB sunscreens, but broad spectrum means one that covers that covers the full spectrum of UV light. You should be looking for one with an SPF of 30 or higher, and needs to be applied about 20 to 30 minutes before going outside. And then in a perfect world, it needs to be reapplied every 20 minutes, or sorry, every 2 hours, which is still a whole lot. That's a lot to ask. I encourage my patients to put some sunscreen on your face and neck every single morning after you brush your teeth. It just should be a thing you do. If you can reapply it during the day, that's even better, especially when you're on your vacation or when you're out and about for the day. Reapplication is critical. So every 2 hours or right after you've been swimming or sweating. Sunscreen can be hard to reapply like that. And so there are lots of other strategies for sun protection, like sun protective clothing. So these are just some examples of some great looking UPF clothing that you can do. So if you have your wardrobe right and you've got your sunscreen on, then you're protected from a few different angles. All right, and then we're almost finished here. I don't need sunscreen because I never go outside. Is that true or false? Okay, that is just not true. I wish I had $1 for every time a patient said that to me because you have to go outside just to get over to my office. So we know that that's just not true. And you'd actually be surprised. So going to the mailbox, walking the dog, and even being in the car. Remember, I mentioned that being in the car is a time where you can get a lot of sun exposure without even thinking about it. So um, here, this is similar to the picture I shared with you at the beginning, but this patient is a truck driver who spent 30 years on the road. And again, almost looks like two different people or two different points in time, but you can see all those deep wrinkles from that sunny side of the window facing on all those years on the road. This is a guide to tan lines, depending on when the vacation was taken and where it was, including 2020 with the big tan line on the face from the mask. All right, so we've talked about a lot of things. I hope you'll remember basal cell carcinoma, the most common kind of skin cancer and the least aggressive. We talked about actinic keratoses, which are precancers that can lead to squamous cell carcinoma. And then we also talked about melanoma and all its different forms. Remember, you should be looking at your skin yourself about once a month. So every place every place on your skin, including using your hand mirror so you can look across your back, you should be looking about once a month and looking for things that are new, things that are changing, and then for sores that don't heal, because remember that basal cell looked like the scab that just never healed. Not everybody needs a professional skin exam. So we know that people who don't have any risk factors, who've never used a tanning bed, who've never had a blistering sunburn, who don't have any personal or family history of skin cancer, they may not need a professional skin exam. And you may be able to look at your skin yourself and determine if you need to see a dermatologist. But other folks who do have those risk factors that I just mentioned, as well as organ transplant, because remember, those patients are at risk for cancer, skin cancer, need to have professional skin exams. And then sunscreen, sunscreen, and sunscreen. SPF of at least 30 is the number to look for. Pale is the new tan. For further reading and some of the things that I shared today, you can see at skincancer.org and at the American Academy of Dermatology.org. And that's all I've got. So I hope that you learned a lot, and I thank you for your attention.
Woo! Thank you, thank you, thank you. And so you have a riveting Q&A, as you can see.
Oh,
As
I
I
can't
noticed from our
wait.
attendees, y'all really participated in that quiz. So I'm going to be
Oh,
sending y'all a
good.
video message if I don't get those post-forum surveys back. So being that we have a lot of questions, we really want to kind of get rolling on those. I want to hit the ground rolling. So first question is from Brianna Webb. And they want to know, for skin cancer prevention, would you recommend tinted sunscreen over regular sunscreen?
Yes, actually. So we know that the color in tinted sunscreen provides a little bit of additional protection for against visible light. So if you're really trying to cover the whole spectrum, then visible light you can block with the tinted sunscreen. So yes, that was a yes or no question. The answer is yes.
Okay, perfect. Thank you for that answer.
I just want to say I've been in a lot of Zoom meetings in my time, and I have never seen one that had more than 99 comments in the chat. You guys are chatty. I'm impressed.
I'm
Wow.
telling you, I told you, they were
Mhm.
really excited to meet you. They were really excited to talk about you. I'm telling
All right, all
you.
right. Well, let's see how far we can get.
Yes. Next question, from Patricia Mills. They want to know, are white physicians more likely to misdiagnose African American patients due to color of skin?
I would say no on the surface there. I think all physicians are at risk of having that bias, but the healthcare world, the world of dermatology does a great job at educating our providers to be suspicious and look for skin cancer.
Yes. Perfect. Um, Next question, from Courtney Rose. What are your thoughts on clothing with UV protection? And then a follow-up from Hillary and Caroline in the same vein. how do I pick out the best swim shirts and when do I know not to trust them anymore? So kind of a two for one, but kind of connected.
Okay, gosh, let me see what I can get. The first question was about UVB protection,
No,
is
so
that
from
right?
clothing with UV protection in it. Yeah.
Oh, right, right, right. So for the clothing, you want to look for the UPF rating. So we think about sunscreen has an SPF, clothing has a UPF rating. And really any UPF rating is acceptable. We don't have hard and fast rules about what's good enough, but by the time it's got that, then it's good enough. And you can choose whatever looks nice, goes with your body. I tell patients it's a great way to cover up the stuff you don't want anybody to see at the beach anyway. And there was a company a few years back whose slogan was, "This sunscreen doesn't wash off." So it's perfect to have on and keep it on all day. The question of when it is worn out is a good one. And we don't have a perfect way to detect that, but hold it up. If you can see the light through the fabric, if it's got any snags or tears, then it's probably time to get something new.
Perfect. All right. And now this one, being that I know we try to entice, I want to answer this one because I see that it's kind of related around a lot of other ones. Vanessa wanted to know, are there any ingredients in skincare, makeup, or similar products used daily that are often overlooked but may be important to be aware of?
Hmm. So in order to be sold and marketed in the US, it has to be the products do have to pass certain safety standards. And so anything that's in there has this designation, generally regarded as safe or grace is how they describe it. So, in terms of risks, certainly they can't protect you against potential skin allergy or something like that, but in terms of general safety, products that you can buy off the shelf do have to have pass some safety standards. They don't have to pass efficacy standards. So if you're looking at buying something that says it will make you look 10 years younger or get rid of all your dark spots or your warts or anything else, you may use your skeptical eye on that because they don't have to prove that kind of thing.
And when you say safety and efficacy, what are you saying? What do you mean? What's that difference? What were you getting at with the
Mhm.
difference between safety and efficacy? Because you made it seem like it was a little bit of a differentiation there. It could be a little bit of snake oil or something.
Yeah, so efficacy means how well it works. So how
Mhm.
well it does the thing that it says it will do. And so they don't have to prove how well it works. And in fact, what you'll see a lot in skincare products is it will say it makes the skin appear younger or it makes it seem one thing or another. They can't make claims that say it will make your skin younger or things like that. So um, cosmetics can only speak to how they might make the skin appear. Safety has to do with, carcinogens and things like that. Is it dangerous to apply?
Makes sense. Okay. So, as you can see, you have the chat live, but again, as we know, again, you're booked and busy. They gotta understand. And so I want to know, do you have time for one more? And if you don't, it's okay because everyone, don't you worry. We're gonna follow up with her and we will get those questions. We got your questions and we'll get answers sent out. So, do you have time for one more? If not, that's okay. Because of
Sure.
course you'll slip it before. You do? Ooh.
Sure, and maybe two more because I saw some things about sunscreen and like how
Mhm,
old it is and can you use last year's sunscreen and things like
mhm,
that. So I just wanted to
mhm.
address that,
So
and
why
then
don't you
I can.
address those points then that way? Because I know it was a couple I
Okay.
saw, and that was the next I was kind of moving towards, which kind of brought me to like the
Sure.
cosmetology stuff. So yeah, please go ahead.
Okay, perfect. Yep. So many sunscreens have an expiration date stamped on there. So you should go by the expiration date that's listed and not use it beyond that and expect to be protected from sun exposure. In general, we say you can keep it for 1 year. So if it doesn't have a date on it, write a date on it when you buy it and expect to use it for about a year from there. And then in terms of storage but also if you are using your sunscreen appropriately, it should not last you a year. So you should be using up that whole bottle and then another and another before the end of the summer. So it really shouldn't last you that long anyway. And then in terms of storage, you do want to keep it with you. So, in your purse or in your beach bag. I love the notion of having your sunscreen in the car so that it's always ready. But honestly, the hot temperatures, which we know it can reach inside the car, is really not conducive to keeping your sunscreen effective. So, if you're in a situation, I sometimes have folks who are like delivery drivers or Uber drivers or things like that. The sun protective clothing, even sun sleeves. So some companies make tubes of sun protective fabric that you basically can slide onto your arms when you get in the car, and then you can take it off when you get where you're going. It's a great way that's not temperature sensitive, that doesn't miss any spots, that doesn't rub off on your clothes. It's always there and available for you. So I don't have any stock in sun protective clothing companies, but maybe I should get some because I'm definitely a big fan of that.
Fabulous. No, thank you so much. Charlotte, hold on, let me get Charlotte. We got one time for one more, you think? One
Okay,
more?
let's do one more.
Okay, come on. Okay, then we
Yeah,
gotta let
then
it go
we're
for it.
I'm
We
gonna
gotta
with
let it go
you.
for it.
I'm with
do
you.
our
Let's do
partner
it.
announcements.
Mhm. Charlotte, did you have one in mind that you want to pick? If not, I can go ahead and pick one that I had in mind. So it's okay. All right, perfect. So this is more community facing. Again, I think moving towards prevention and what we can do. So Shantanay Jackson, which hey, Shantanay, she wanted to know, as a CHW, we hear and see people in the early stages of prevention in the community. What are some educational tools or screenings that you recommend sharing as a resource that support communities?
Hmm. I think education is really a big piece of this, and hopefully it came through when I pointed out sometimes we are not suspicious enough of ourselves. Sometimes our doctors are not suspicious enough of us. And so I think when working in the community, emphasizing patients should be looking at their skin themselves and what to look for. So things that are just different than any of your other spots, sores that don't heal, and stuff that's changing over time. And then really emphasizing too the importance, especially for patients of color, to be looking on palms and soles, and nail beds too. So some people keep their nails painted all the time and they don't even know what's going on under there. It's important to take a look at your nails when the polish is changed. And to know yourself, know your body, know where your moles are, what your spots are like.
Perfect. That was a phenomenal answer. As you can see from the chat, some more they already love what you were saying. So again,
Okay.
just thank you so much. And to everybody that dropped those questions eagerly, we thank you so much. And don't you worry. Again, I promise you, we're gonna hunt her down. I will come to AOP myself. Have to.
That's where
We
I
will
am
get
right
these.
now.
We will get these questions answered for you and sent out in the follow-up email. So to everybody that dropped the question, thank you so much. And again, give Dr. Saki a round of applause.
Thank you so much. You've been a great audience. I really appreciate it.
Of course, thank you
I'm
so
going to
much.
get back to my clinic, but
Yeah,
again, thank you so much for having me. I'm happy to answer questions later.
Thank you
of
for
Okay,
course.
being
It's
with
bye,
such a
us.
everybody.
pleasure.
Learned
Thank
a lot.
you.
Are you or someone you love eligible for screening? Get support from the Massey COE. So on some of those screenings, you'll see eligibility screeners for cancer. So we have prostate cancer, lung cancer, and colorectal cancer. Please scan those. If you do those, you can actually fill out a question that'll tell you your eligibility for that screening. And for our CHWs or community organizations, you can actually use that out in the community as well. So you will see that dropped in the chat and you will see a QR code. If you have any questions, again, use the same contact info, engage Massey or the number. Connect with Mass COE. So we have the link tree, which has a plethora of resources. It's your one-stop shop. So if you don't know where to start or you're looking for your starting point, maybe scan that first QR code. If you're looking for Mass to support your event, so historically, you may have reached out to somebody personally, but again, we're asked that you fill out the Massey event portal if you're looking for our attendance at the event or our support or materials. And if you were so inclined and you're looking to actually engage us even further, please scan the Volunteer with Massey link where you can sign up to be notified when we have our volunteer training for our Massey volunteers, which is coming soon. Save the date. So for our next forum, we'll actually have Dr. Jack Melson, and our topic will be drum roll please. Men's health and cancer. So that's happening June 23rd, 2026 from 1 to 2 p.m. If you haven't already, please scan the register. And if you haven't planned to already, bring a friend with you. And for those that have been super involved, host a watch party. So with all that being said, it's really nothing left to be said. I'll see you next month. Thanks for coming out.